I'm going to talk about the pathological part of malaria's life cycle. There are two different forms that I'm going to talk about that cause the most problems with malaria, and Plasmodium. Plasmodium vivax species causes 80% of malaria infections, and that's because it attacks the Duffy antigen of the red blood cells. And so that's only present on old and young red blood cells, so it only affects those two parts of the red blood cell. That's why people still have healthy red blood cells if they have that type of malaria, and it isn't as serious. Falciparum malaria, it only affects 15% of people who are affected with malaria, but it can affect any age red blood cell, so even your healthy cells, because it affects the sialic acid, and that's present in all ages of red blood cells. Some people in places where malaria is endemic and very common can develop other mutations in their blood cells to be resistant to malaria. So some things they can have that give them a more resistance to malaria are Melanesian elliptocytosis. That's just a different shape of red blood cell due to different proteins and blebbing off. They can have hemoglobin alterations, such as sickle cell disease, because malaria trophozoites feed off the hemoglobin to reproduce for nutrients. And also a G6PD deficiency can increase your resistance to malaria. So just the pathological portion of the life cycle of malaria is what I'm going to talk about. So after they leave the liver, the merozoites are in the blood, and they invade the red blood cells. And then they turn into trophozoites, and the trophozoites feed on the hemoglobin, so they're taking nutrients away from the body, and they're going to create more and more merozoites until the red blood cell gets completely full that it needs to lyse. And so all of these red blood cells in circulation kind of lyse on the same time. There's a signal somehow. So then all the merozoites leave the blood cell that's lysed into the blood, and it starts to cycle again, where it starts infecting other red blood cells and going through the cycle again. And so that's what causes the symptoms of malaria, is when they lyse and go out. When you're infected, the bacteria has, or the malaria has an incubation period of 7 to 10 days before you actually see symptoms. And then you'll go to a quotidian fever, and that's every day, and about 24 hours. And so that's how you can see the red blood cells lysing kind of in sequence. And symptoms you would see with the fever, you'd also see nausea, vomiting, and diarrhea. And then you would progress to malignant tertian malaria, and that's every 36 to 48 hours. So about every other day you'd be having these symptoms with the fever, and that's malignant and fatal. Versus the vivax, Plasmodium vivax, has a benign tertian malaria, so it's not as potent. Other associations that might come with malaria are cerebral malaria, black water fever, which is kidney damage, and liver involvement, based off of where these trophozoites and merozoites are reproducing. To diagnose malaria, you need a blood smear and GM stain. For falciparum, you would see banana gametocytes. Gametocytes are the sexual organisms of malaria that get picked up by a new Anopheles mosquito to spread to a new person. And then with the vivax species, you would see Schuffner dots in the trophozoites on a blood smear. There are different treatments depending on resistance. A lot of malaria are now resistant to certain chloroquinones. So I'm just going to talk about, so vivax and ovale are the type of malarias that can live in your liver and give you chronic infections. And so to treat those chronic infections of vivax and ovale, you treat with primaquine, and you want to pre-screen for G6PD deficiency before treating with primaquine, because primaquine given to somebody with G6PD deficiency can cause hemolytic anemia, which can be fatal.